Welcome, everyone. I'm Dr. Ben Buchanan, a clinical psychologist and the CEO of NovoPsych, and I'm absolutely thrilled to be hosting tonight's webinar on death anxiety with Dr. Rachel Menzies. I love running these sessions because they give us a chance to connect with the people who use NovoPsych, psychologists, psychiatrists, counselors, social workers, CBT therapists, GPs, and all sorts of mental health professionals around the world who are passionate about improving care and who know that high quality assessments is part of that. And we've had over 1,000 people register for tonight's event, which is testament to the mental health community's commitment to continually building skills to better serve our clients. At NovoPsych, we provide a range of psychological measures. We'll learn about one of them tonight. And I know that many of you have been using these tools for years. And so I want to welcome everyone from across the globe. I see names popping up in the chat, people from Western Australia, Queensland, the UK, Singapore, South Africa, and of course, right here in Melbourne, where I'm tuning in from, and Sydney, where Rachel is. Tonight is an opportunity to understand some underlining theoretical frameworks relevant to death anxiety. And fear of death is near universal, but for many, it quietly drives a wide range of psychological difficulties. And we're very lucky to have Dr. Rachel Menzies' expertise tonight guiding us through. I always think that self-administering scales is such a wonderful way of understanding what it might be like for a client to do it. And also from the content that we hear from tonight, you might not only be able to apply it to your clients, but if you've self-administered the scale, it might also be useful reflection for yourself. After all, us therapists and clients are all in it together. So, without further ado, I would like to introduce our wonderful guest. Dr. Menzies is a clinical psychologist, research fellow, and lecturer at the School of Psychology at the University of Sydney. Rachel is an award-winning researcher whose work on death anxiety has been recognized internationally. She has delivered workshops and trainings for clinicians across Australia and beyond, and is a true leader in understanding death anxiety's interaction with mental health. She is the founder of the Menzies Anxiety Centre in Sydney, and her clinical work focuses on death anxiety using CBT. She has led national tours on death anxiety, contributes to leading academic journals, and serves on boards including the International Society of the Science of Existential Psychology. Rachel's research and commentary on existential issues have been widely published, and I've even spotted her in the media a few times. So, hey, Rachel, welcome.
Thank you so much, Ben. Thank you to you and the team at NovoPsych for having me this evening.
Oh, it's an absolute pleasure. Hey, Rachel, before we get into it, I'm interested in how did you become interested in death anxiety?
So I did a combined degree in psychology and ancient history here at the University of Sydney, where I am tonight. And in ancient history, we learn a lot about the different ways various cultures across time and place have handled death and responded to death. And then in my social psychology sphere of my studies, I was learning about one of the main social psychological theories of death anxiety, which I'll talk a bit about tonight. And so it was really this kind of dovetailing of passion for ancient history, starting to learn about social psych and its handling of death that led me to get into this area.
Gosh, that's quite highbrow. I thought you were going to say that you were a goth as a teenager,
No, nothing
but
quite so interesting.
studying
Yep.
ancient history at university is much more refined.
Much
Um,
nerdier.
yeah. Um, and you've obviously developed the questionnaire that measures death anxiety. I want to know how you score on it and what your relationship with mortality is like yourself.
That's a good question. I couldn't tell you my exact score, but I've before developing this measure, I've measured my death anxiety on pre-existing measures over the years, and it's certainly declined the longer I've done this work, which I think is a real testament to exposure therapy and the sorts of treatment approaches I'll talk about tonight. I do think the more you do this kind of work, definitely the more comfortable you get with death.
Yeah, great. Well, Rachel, really looking forward to what you've got to say tonight. I'll hand over to you.
Ben has already given a very generous and helpful introduction to me and my work. As Ben mentioned, I work here as a researcher at the University of Sydney, and a lot of my research, which I'll go through some of tonight, has really highlighted the importance of death anxiety in mental health and the need for treatments which target fears of death. The more research we have on this topic, the more the public is becoming aware of death and death anxiety. And so the more need we have for clinicians who are able and interested in treating this transdiagnostic construct. And so it was really this that led me to open the Menzies Anxiety Centre. We focus on treatments for death anxiety, as well as conducting research in the topic of death anxiety, and as well as delivering training, workshops, supervision, and so forth. So it's fantastic that there were so many people interested in this topic tonight, because we really do need many more clinicians who are interested in this area and upskilling in order to meet the growing public demand for death anxiety treatment. So, the awareness of death is really a central part of being human. For as long as humans have been recording our history, we've seen fears of death really as one of the universal themes. William James famously referred to our awareness of our own death as the worm at the core of human existence. And if you look across essentially every aspect of human culture, you see fears of death coming up time and time again. If we take literature as an example, this here is a tablet from the oldest surviving great work of literature that we have, which is the 4,000-year-old epic poem, the Epic of Gilgamesh. And this tells the story of King Gilgamesh, who witnesses the death of a close friend. Gilgamesh is distraught by this death and by his sudden realization that he too will die one day. So this leads him to go on a lengthy quest to try and find the secret to immortality before he's eventually forced to accept the fact that he is mortal. So at the heart of the oldest surviving work of literature that we have is this fear of death and the desire for immortality. This theme wasn't unique to the ancient Babylonians. We see this theme time and time again across literature. If we take Shakespeare as another prominent example, more than half of Shakespeare's plays deal explicitly with death and fears of death, including his most famous scenes, such as the to be or not to be soliloquy and the graveyard scene in Hamlet, where Hamlet finds the skull of the court jester Yorick. Religion is another way that humans have tried to grapple with this fear. All religions offer some kind of solution to the problem of death. And images of death feature across religions. In 14th century Europe, it was commonplace for Catholic monks to keep a human skull, a real human skull, on their desk as a reminder of mortality. And skulls have been used as ritual objects in other traditions. This here is a kapala, which is used as a ritual object in Tibetan Buddhism. This is a real human skull, which, as you can see, is decorated and used for ritual. So ritual is another way that we can start to see the prominence of this fear. If we look at some of the oldest rituals that we have good evidence for, the ancient Egyptian mummification rituals are one of these. It was a hugely ambitious and time-consuming project in ancient Egypt to mummify a body. It took on average 70 days to mummify a corpse. And every step in this process had one goal, and that was to keep a corpse looking as lifelike as possible for as long as possible in order to ensure the immortality of the dead. So clearly a real desperate attempt to deny the physicality of the corpse and to try and gain immortality. Art is another way that humans have grappled with this fear. There are two whole genres of art which deal explicitly and solely with death. One is the dance macabre, which is pictured here, which depicts skeletons leading people of various social classes to their grave. And the other is the vanitas genre of art, which uses more symbolic imagery to remind the viewer of their own death. But every artist has dealt with this theme in some form, from Frida Kahlo to Andy Warhol to Salvador Dali to Gustav Klimt, Escher, Edvard Munch. This particular image by Munch is called The Sick Child, and it depicts his sister on her deathbed before she died of tuberculosis. Munch was fixated on this moment. He did 6 paintings of this exact scene, more than 40 drawings of this exact moment, clearly a man that was struggling to come to terms with the death of his sister. And similarly, in Pablo Picasso's self-portrait, titled Self-Portrait of a Man Facing Death, one of his last self-portraits, you get a real sense of the terror that Picasso experienced as the end of his life approached. So for as long as humans have been recording our history, we've used every cultural tool at our disposal to try and express and grapple with this fear. But it wasn't until 1973 that we had the first attempt to develop a theory of death anxiety. And this wasn't in psychology, it was by a cultural anthropologist named Ernest Becker, who won the Pulitzer Prize for his book, The Denial of Death. Becker argued that humans have an innate desire to live, but we also know that our death is inevitable, and this combination can produce a crippling fear. Then a decade later came terror management theory. Now, this is a social psychological theory that was really an attempt to extend Becker's work and develop it into a series of testable scientific hypotheses. So terror management theory, or TMT, argues that humans have 2 main buffers against death anxiety. The first buffer are cultural worldviews. So these are shared belief systems, shared values, shared norms, and they argue that we gain a sense of virtual immortality by buying into these shared cultural worldviews. So for example, we could have cultural worldviews such as valuing educational achievements, academic achievements, cultural worldviews such as valuing consumerism, materialism, financial achievements. Cultural worldviews, they argue, can also involve being part of a movement or a group, such as a particular political or protest movement, because we're becoming part of a group or a movement that will outlast the self. Or cultural worldviews of a religious nature, such as a belief in the afterlife. So according to TMT, by buying into the beliefs, the values of our culture or subculture, we become part of something bigger than ourselves, and this gives us virtual immortality. The second buffer they propose is self-esteem, in that by fulfilling the expectations of our cultural worldview, we gain a sense of meaning and significance. So if my subculture values academic achievements, then every time I publish a paper or give a talk, it boosts my self-esteem, it makes me feel like I'm an important, special person, and that I'll be remembered fondly after I die. So according to TMT, death anxiety may explain much of human behavior. There have now been over 500 mortality salient studies run. These are studies in which mortality is made salient, so people are reminded of death in the laboratory, and these have shown the broad range of ways that death anxiety drives human behavior. So for example, we know that reminders of death make people more aggressive to people who hold different cultural worldviews, such as people of a different religious background or political ideology. Reminders of death make people want to spend more money, particularly on high status luxury goods that are going to boost self-esteem. And reminders of death make people assign harsher punishments to people who transgress social norms. But what about clinically relevant behavior? Why might this be relevant? So in 2014, myself and colleagues published this article arguing that death anxiety might be transdiagnostic, meaning that it might underpin and account for a range of different mental health conditions. And if we start to look at some of the common mental health conditions, we can see the relevance of this fear. So in panic disorder, where people are worried about that tight chest, that it could be a heart attack. in health anxiety, where people are requesting a lot of medical tests, seeing their doctor a lot. In agoraphobia, where people are scared to leave their house in case something bad happens to them. In all of the common specific phobias, fears of flying, fears of heights, fears of spiders, all of these, of course, are things which could directly kill you. And in OCD, in the checking type of OCD, where people are checking stovetops, electrical outlets because of fears of fire, electrocution. And in the contamination type of OCD, where people are compulsively washing to prevent some kind of serious illness. And so if death anxiety is underlying these disorders, then this could explain the revolving door of mental health services, in which it's not uncommon for someone to present as a child with something like separation anxiety, to receive treatment for that, then to return to treatment as an adolescent with something like OCD, again to get treatment, and then to return again as an adult with something that looks quite different, such as panic disorder. So the question is, are these disorders truly independent, discrete events, or is death anxiety possibly underlying these? Now, at the time when we wrote this paper in 2014, this revolving door idea was really just a clinical observation. But last year we conducted a meta-analysis to see if there was actually empirical evidence for this revolving door. We analyzed data from more than 23,000 people. And what we found was that on average, the number of lifetime disorders someone has is nearly double current disorders. So what does that mean? That means that if someone walks into your office today and they currently meet criteria for 2 disorders, across their lifetime, they're likely to have had 4. So they're likely, on average, to have previously had 2 disorders that they've since recovered from, and now they're presenting with 2 different disorders. So this is the first empirical evidence for this idea that people do cycle through mental health conditions across their life. And this is really why we need transdiagnostic treatments. So I'm going to try and walk you through a snapshot at some of the early evidence linking death anxiety to different mental health conditions. Specific phobias are the disorder which have been linked to death anxiety for the longest time. So as early as Freud, fears of death were argued to be central to these to phobias. And various studies had shown that death anxiety is correlated with the severity of phobias. In panic disorder, fears of death have been argued to be central. We know that panic disorder patients have significantly higher death anxiety than controls, and death anxiety is correlated with disorder severity. In agoraphobia, some of Edna Foer's early work showed that fears of death are associated with many symptoms of agoraphobia, and that in fact the onset of this disorder is often preceded by some kind of physical threat or loss, such as illness or death. And we know that death anxiety is correlated with the severity of this disorder. In OCD, some of my work has shown that death anxiety is correlated with all 6 symptom domains of OCD, including things like checking, washing, aggressive obsessions, where the fear is that what if my thoughts could kill? What if I have an image of pushing someone in front of the train or throwing myself in front of the train? And that means that I actually do it and I cause death through thinking. In health anxiety, we know that patients with health anxiety have significantly higher death anxiety than controls and other patients, and that fears of death are correlated with symptom severity. In depressive disorders, there's an argument that these disorders might be exacerbated by meaninglessness and existential despair. And you might often hear depressed patients say things like, I get up, I eat, I go to work, I come home, I do it all again. What's the point of anything I do? What's the point of doing anything if this is all going to turn to dust one day? And there have been various studies in different populations showing that death anxiety is correlated with the severity of depression. Alcohol use disorder, not necessarily a type of disorder that you would think of as being linked to death anxiety, but there's a hypothesis known as the existential escape hypothesis, which is essentially the idea that one way some people with death anxiety might try and cope with this fear is through numbing and self-medication. Studies have shown that death anxiety is associated with the severity of addiction. Social anxiety, again, not a disorder that you might think of as being directly related to death. But there are arguments from evolutionary psychology that social anxiety might stem from death anxiety. Humans are an inherently social species, and throughout our evolutionary history, we've relied on being part of a tribe in order to survive. An early human who was ostracized and kicked out of the tribe was very unlikely to survive. And so, from an evolutionary point of view, fears of death might be underpinning this condition. And a couple of studies now have shown that death anxiety is correlated with social anxiety symptoms. PTSD is a disorder where death or confrontation with death is actually built into the DSM-5 criteria for this disorder. And again, various studies in PTSD have shown that death anxiety is associated with the severity of this condition. And lastly, eating disorders. Interesting Australian study that showed that death anxiety was correlated with disordered eating, but that this relationship even remained significant after controlling for things like perfectionism, low self-esteem, and more. So most of the research so far has looked at these disorders in individual silos. There hadn't been any research that was really looking kind of across different disorders transdiagnostically. So we conducted a study where we had 200 treatment-seeking participants that represented 17 different mental illnesses. We gave them measures of death anxiety and measures of different mental health outcomes, and we found that across the sample, death anxiety predicted a clinician's judgment of the person's distress, the number of medications they're on for mental health, the number of times they've been hospitalized for mental health, their depression, stress, and anxiety scores, and also the number of diagnoses they've had across their lifespan, building support for this revolving door idea. When we looked at individual disorders, for every disorder that we had sufficient participants for, we found these large to very large correlations between death anxiety and that disorder. And that included OCD, GAD, major depression, social anxiety, panic disorder, illness anxiety, somatic symptom disorder, alcohol use disorder, and more. And importantly, all of these relationships remain significant after controlling for neuroticism. So it doesn't seem like it's just someone's general predisposition to anxiety that's explaining this relationship. There seems to be something unique about the relationship between death anxiety and these different disorders. Now, all of that research is cross-sectional, but of course, we can't conclude anything about causality from cross-sectional studies, from survey-based studies. So how do we test whether death anxiety is actually causing mental health symptoms? This is where we really need experimental studies. So if death anxiety is causing a disorder, then reminding people of death should increase behaviours that are relevant to that disorder. And this is where the mortality salience paradigm comes in that I mentioned earlier. So in mortality salience studies, half of the participants are randomly allocated to get a reminder of death. And this is typically in the form of these two brief questions. Please briefly describe the emotions that the thought of your own death arouses in you, and jot down as specifically as you can what you think will happen to you as you physically die. Or they're in the control condition. The most common control condition used is dental pain, where it's identically worded questions, but replacing the word death with dental pain. And this is because dental pain is something which is unpleasant and aversive, but it is not something that should indirectly get people thinking about death. So people receive one of these two questions or conditions, and these questions are buried in a much larger pack of questionnaires. So people might be filling out 100 questions, but buried in that questionnaire pack, they're getting these two brief questions, either about death or dental pain in the control condition. So there have been a handful of studies done in community samples using this design. Using this design, mortality salience, so those reminders of death, have been shown to increase behaviours relevant to social anxiety. So we know that reminders of death make socially anxious individuals go to greater lengths to avoid a group discussion. So they show more social avoidance after being reminded of death. Alcohol use disorder, in a really interesting field study at a nightclub, this research team found that reminders of death actually make people consume more alcohol compared to a control condition. Eating disorders, reminders of death have been shown to make women, but not men, choose smaller portions of high-fat, high-calorie foods, so they're restricting their eating, and rate themselves as being further from their ideal thinness, suggesting that death anxiety is driving women to strive for the thinness which is promoted by their cultural worldview. And you find the opposite pattern in men than you do for women. So women reminded of death show behavior suggesting they're striving to be thinner. Men reminded of death show these kind of behaviors that characterize muscle dysmorphia. So they, instead of wanting to restrict food, they select larger portions of food, consistent with the idea that they're trying to build muscle mass, because cultural worldviews and beauty norms for men are all about muscularity rather than thinness. And men who have been reminded of death also report having exercised more than those in the control condition. So these have all been done in community samples. What about clinical samples? There have only been a couple of studies done using treatment-seeking clinical samples. One study showed that in people with a spider phobia, reminders of death led to greater avoidance of spider-related stimuli and greater threat perception. People rated spiders as being more lethal when they'd been reminded of death. And one of my early studies looked at mortality salience and OCD. So to describe this study in a nutshell, we had a large sample of people with OCD. Half of them had the washing type of OCD and half of them were non-washers. Half were randomly allocated to the death mortality salience condition. The other half were in the control condition. We told them we were measuring their skin conductance, so that their galvanic skin response on a performance task. And for that purpose, we told them we'd be applying some conductive gel to their fingers and measuring that via some electrodes. This was all part of our cover story. We were actually interested in measuring washing behavior and how long they would spend washing their hands. But to get them to wash their hands, we needed a cover story and to put something on their fingers to give us an opportunity to ask them to wash and to measure their washing behavior. So we put this gel on their hands, we did this kind of fake task, and then simply asked them to wash the gel off their hands before they returned to the experimental room. And what we found was that when we measured their washing duration, so this was me audio recording how long they were spending washing their hands, a non-washer in the death condition is not averaging any longer time at the sink than appear in the dental pain control condition. But when we look at the behavior of people with the washing type of OCD, you can see that someone who's been reminded of death is averaging a 21-second hand wash. This is double the time spent washing compared to a washer who had been reminded of dental pain in the control condition. And importantly, in all of these studies, a typical part of the methodology is that you measure on self-report measures people's affect between the death and the dental pain condition. So after all of this, we give people questionnaires asking them, how anxious do you feel right now? How contaminated do you feel right now? How comfortable do you feel right now? How sad do you feel right now? And consistently in this literature, you find no significant difference on these conscious measures of self-report affect. So it's not the case that this group primed with death are consciously reporting feeling any more contaminated or any more anxious than the control condition. And yet, when you surreptitiously measure people's behavior, in this case at the sink, you see this significant increase in how long these patients are spending washing. So this is causal evidence suggesting that death anxiety is underlying at least the contamination type of OCD. We've also done a similar study in panic disorder, illness, anxiety, and somatic symptom disorder. In this study, we found that reminders of death increased how long people spend checking their body for symptoms of illness, or physical symptoms actually more generally. Reminders of death also make people more likely to interpret benign physical symptoms as being dangerous and increase people's intention to see their GP or medical specialist. So when we ask people, how likely are you to want to see your GP more than usual in the future? In the dental pain control condition, only about 12% of people say, I want to see my doctor more than usual in the next couple of months. But people who have been reminded of death, for them, more than half of them are now saying, I want to see my doctor very soon. So again, this is experimental evidence suggesting that death anxiety is actually playing a causal role in the sorts of anxious behaviours that people seek treatment for. Now, this is a rapidly evolving field. There are more and more studies looking at the relevance of death anxiety to different mental health conditions. This is a snapshot of where the literature is up to currently. At the time of me making these slides, I'm often updating this slide. And what you can see is that every disorder on here has been linked in some way empirically with death anxiety, but the level of evidence is really variable. So the dotted lines, we just have correlational evidence. The thin but solid lines, we have experimental evidence, but not in treatment-seeking samples. And then finally, we have the strongest evidence with these thick bold lines, where we have experimental studies using treatment-seeking diagnosed samples. So we can most robustly conclude for these disorders that death anxiety is playing a causal role in patients seeking treatment for these conditions. So last year, we published this meta-analysis where we wanted to try and calculate, on the whole, what is the relationship between death anxiety and psychopathology. I'm going to try and move through this quickly because I've got a QR code if you want to read this in more depth. But essentially, we analysed data from 110 studies with more than 24,000 participants. When we looked at cross-sectional studies, we found a moderate relationship between death anxiety and overall mental illness symptoms. But there were a couple of things that moderated this relationship. We found larger effects for clinical samples for anxiety compared with depression. So the relationship between depression and death anxiety was still significant, but smaller than that found for anxiety symptoms and death anxiety. And it was different depending on the type of anxiety-related disorder. So for all anxiety-related disorders, there was a significant relationship, but it was significantly larger for anxiety disorders and somatic symptom disorders compared with OCD and trauma. We also wanted to look at the experimental mortality salient studies which were out there. And these studies essentially replicated what we found in the cross-sectional studies. So on the whole, there was this moderate effect of mortality salience on mental illness symptoms, and again, a large effect found for clinical samples. So pulling this all together, data from 24,000 people is really suggesting that on average, there's a medium-sized relationship between mental illness and death anxiety, but when you look at clinical samples, there's this much larger relationship. And as I mentioned, if you're interested in reading this more, there's a QR code there for you. So what are the implications of all of this? So terror management theory and recent research suggest a very different approach to treatment than what many of us are probably doing currently. Most of our treatments for anxiety more generally, tend to focus on specific causes of death. So for example, in panic disorder, you might get people doing behavioral experiments where you're getting them running upstairs, doing exercise to show them that that racing heart is not actually a sign of a heart attack, that their heart is sound. So you're targeting that specific cause of death, the fear of the heart attack, which does a very good job at addressing that, but probably is failing to address that underlying fear of death. The person knows they're going to die of something, they might just now not think it's a heart attack. Similarly, in ERP for OCD, you might get people touching things like doorknobs or other things that are seen as contaminating. Again, this is doing a really good job at addressing that fear of illness, but why would this address any kind of underlying existential issue? So if we want to try and slow the revolving door and ensure long-term treatment success for patients, we may need innovative treatments which actually address that underlying fear of death. So this raises the question of when to treat death anxiety. Do we just blindly go into treatment for all clients with this in mind, or do we need to be more selective? So in a nutshell, we want to, of course, base this on assessment and clinical formulation. And in terms of assessment, of course, thinking about a clinical interview. So if you were getting the sense from someone's presentation that a lot of their fears seem to come back to this underlying, sort of downward arrow fear of death, then this is giving you really important information clinically. And also considering self-report death anxiety measures if you're wanting to screen for this more in your clients. And this is what led me to develop the Death Anxiety Beliefs and Behaviour Scale, which many of you would have completed tonight. So this is an 18-item measure, and it was really developed because of another review we conducted showing that most of the death anxiety measures out there simply don't have good psychometric properties, and none of them are actually developed for clinical samples. So we developed this measure as a brief and clinically useful measure. It's the only measure that has a clinical cutoff when it comes to death anxiety. So a score of 55 or higher would indicate someone has clinically significant death anxiety. It's of course available on NovaPsych, and I'll show you what that looks like in a second. And importantly, it was designed to guide CBT-based treatment. So you can use it simply as a screener or to track pre and post-treatment change, but it's also designed to inform interventions. And so what I mean by that is that it's got these three subscales. We have an affect subscale, we have a belief subscale, and we have a behavior subscale. And these latter two subscales here are specifically designed to inform CBT treatments. So the belief subscale is going to show you what are some of the maladaptive beliefs about death that my client might be endorsing. This is going to be important to target in cognitive challenging. And also, what are some of the avoidance behaviors, the maladaptive avoidance behaviors that my client might be engaging in? And these might be important to target in things like exposure therapy. So it was really designed with treatment in mind. I'm going to present a brief case example to illustrate how the DABs can be useful for screening for death anxiety and informing treatment. So this was a client of mine named Jane who presented for death anxiety. Jane was a woman in her mid-40s. She described having a lot of fears of death, particularly the idea of non-existence. So she had these images of death being a blackness, an annihilation, and in her words, an abandonment. She would spend a lot of time ruminating on deaths that she heard about in the news. She would frequently experience panic attacks at night when lying in bed and thinking about death. She was in what she described as a codependent relationship with her husband and would frequently experience a lot of worries, excessive worries about her husband's safety, in addition to worries about her own death. She also had symptoms of social anxiety, a lot of fear of negative evaluation, and some trauma-like symptoms after she'd been in a very minor car accident a few years before. So, for example, she avoided driving. That's partly how her death anxiety manifested. But her symptoms wouldn't meet the full diagnostic criteria for social anxiety or PTSD. So I think she's a good example of the kind of transdiagnostic nature of a lot of this anxiety. She had social anxiety symptoms, trauma-like symptoms, this kind of excessive concerns about safety, natural disasters, and so on. Quite a varied presentation. In terms of her history, she described having quite an unstable childhood. Her father was quite an erratic and unusual man. He was highly religious, quite zealous in his religious faith, and she cut contact with him when she was quite young. Her mother she described as very unsupportive, very unstable and unpredictable. She lived with her mother, but they were frequently relocating. So Jane went to various schools, I think maybe 5 or 6 schools across her schooling years, moved interstate regularly with her mother, and that whole childhood was quite unpredictable and unstable. So Jane presented to me for treatment, and I gave her the DABs at baseline when she first presented. This shows you her scores here. So what you can see is that her total death anxiety score, she was scoring 70, and remember the clinical cutoff is 55. So anything in this high, these kind of pink or red bars is in the clinical range. This here on this axis is percentiles. So you can see that her total score was putting her in the 95th community percentile. So clearly very high death anxiety. And when you look at her subscale scores, you can see that all three are in the clinical range. All of them are in these kind of pink-red bars. But what you can see in particular is that her affect is very high and her behaviors are very high. So this already to me is telling me that we're definitely going to work or wanted to work on some exposure to target some of these things that she was telling me she avoided a lot, but also looking at her beliefs, because even here, the frequency with which she endorsed these kind of maladaptive beliefs about death is giving me some useful information about us needing to do some cognitive work around those. So I'm going to come back to Jane later once we've talked a bit more about treatment. But this gives you an example of how you can use the DABs and the kind of information it gives you. So how do we actually treat death anxiety? In 2018, we published this meta-analysis. You're probably getting a sense that I love publishing meta-analyses. This was a meta-analysis of randomized controlled trials for death anxiety. We included all 15 RCTs that existed at the time, and these represented 5 RCTs looking at death education meaning didactic lecture-style workshops about death and dying. These are typically delivered to medical students, nursing students, and so on about the dying process. 5 studies which used CBT, and lastly, 5 studies which each represented various different therapy types. And the vast majority of studies used a group-based format for these interventions. Overall, interventions reduced death anxiety, but there were a few key moderators. And the big one, in my view, is intervention type. Death education failed to reduce death fears, so simply teaching people about death and dying did not seem to significantly improve death anxiety. And in fact, it was only CBT that significantly reduced death anxiety compared to the control condition. Another moderator was baseline death anxiety, meaning that studies that recruited people who specifically had high levels of death anxiety tended to do better. And the number of sessions, but not the overall duration of treatment, made a difference. So the greater the number of sessions, the frequency of sessions, the more improvement people showed. So in short, these are the main implications. Firstly, we know now that CBT reduces fear of death. In particular, the CBT studies in this meta-analysis focused on graded exposure therapy. So we now know that graded exposure therapy seems to be the most efficacious way of reducing this fear. And we know it works for highly death anxious individuals. To me, one of the takeaways of this is that exposure really needs to be individualized and systematic. Now, this isn't news. We know that this is the case for exposure therapy more broadly for anxiety. But to me, the fact that death education, that's simply being exposed to generic information about death and dying, didn't seem to be effective, speaks to this idea that we need to be deliberately targeting individuals' own unique fears about death with exposure therapy. And lastly, that the dose is really important. So the greater number of treatment sessions we know has greater efficacy, which again is consistent with what we know about exposure therapy for anxiety more broadly. So what does exposure look like when it comes to death and death anxiety? Exposure can look really varied. So it could involve, for example, things like going to places that the person associates with death. It could be going to cemeteries, going to hospitals, going to funeral homes. It can be reading. It can be reading fictional stories, such as The Death of Ivan Ilyich. Reading novels with characters who die would be an example of exposure therapy. It could be reading memoirs written by people who are terminally ill or people who work in death-facing professions. It could be TV or film or documentaries, whether fictional, whether non-fictional. I've finally started watching 6 Feet Under. It's a bit nuts that it's taken me so long to get to this show. I've had so many patients and colleagues recommend it to me. Excellent show for those of you who haven't watched it and perfect for exposure. Each episode opens with, so 6 Feet Under, for those of you who haven't seen it, focuses on a family-run funeral home. It's quite a dysfunctional family, and it's sort of a drama following the family. But each episode opens with a death in the community, and the person that dies is the body that is going to be prepared by the funeral home, by this family, that particular episode. So it's a great show in terms of normalizing death, normalizing that death can come at any time. And this is a real thing that we need to face. So various shows you could use, but this is just one that I've been liking recently. Any films that deal with impermanence, death, again, whether these are documentary films or whether they're fiction, could also be useful exposure tasks. Anything as well with exposure that seeks to add a bit of lightness in addition to normalizing death can be particularly powerful. So this book, Everybody Dies, a children's book for grown-ups by Ken Tanaka, is really trying to do that. It uses cartoon-like illustrations and attempts at humor to try and inject a bit of lightness into the discussion around death. So these are just a handful of tasks that you could use or ideas you could use. Of course, with exposure, we want it to be as individualized as possible. So if a person tells you that they are particularly afraid of cancer, for example, then you're going to want them reading or watching things to do with cancer. If someone's fear is around losing a parent or a spouse or a loved one in general, you're going to want them as much as possible engaging with material that is centering on that particular fear. And that can include things like writing what you might be familiar with as an illness story in the illness anxiety, health anxiety literature. So it could be writing a kind of detailed first person story for imaginal exposure, imagining that feared scenario, whether that's their own death, the death of a loved one, and so forth. Anything that's getting them facing the fear and starting to help normalize death as well. So there are various other more practical tasks that you can do as exposure. It could be reading obituaries, but also writing one's own obituary, or preparing one's own will. So again, any task that's really driving home the reality of death and helping the person face the fear instead of avoid. In acceptance and commitment therapy, they've advocated for the use of things like the tombstone task, where you're writing your own tombstone inscription, or of course the eulogy task, where you're writing your own eulogy. These tasks were not developed for the purpose of exposure therapy. They were developed as values clarification tasks, but I would argue, would have this dual benefit. You're partly wanting the person to just start to normalize the idea that they will die, they will have a funeral, there is likely to be a eulogy, as well as helping people think about how they actually want to live with the time that they have. For any of you working with young people, the same. We have far less data on treatment of death anxiety in children and young people, but one would expect the same sorts of principles to apply for exposure. And these are just a handful of example exposure tasks aimed at younger people. These picture books here, The Happiest Day of My Life, features a little boy named Harry who learns about death and is very scared about death. And it tells the story of how he learns to accept death. This story, Bartholomew and the Bug, is about this little bug here who only has one day to live. And he wants to make the most of his one day, of his very short lifespan. He wants to get to the city, see the lights, dance and party until the book ends with his death. And then, of course, some of these wonderful films that I'm sure many of you have seen, films like Up and Coco. But if you start to do more work in the death anxiety space, you'll start to collect more and more of different exposure tasks that you might find particularly useful. These are just some of the ones that I often use. Apps and games are another really good way of getting a good dose of exposure therapy. So there are apps such as this app called WeCroak, which multiple times a day will prompt you with a reminder on your phone that says, "Remember, you will die." Um, you can see it's trying to get a really high dose of exposure there, even though it's not necessarily wasn't designed as an exposure focused app. But it does a really good job at driving home the acceptance of mortality and normalizing it. And I've had many clients who have used this app who have commented on the fact that when they get that reminder come up on their phone, it can really help refocus them on what actually matters to them. So perhaps they were anxious about a deadline at work or an argument with their partner, and then up comes this reminder of mortality, and it really helps them put things in perspective and live a bit more deliberately, I suppose, in the moment. There are other games. This one here is a mobile game called A Mortician's Tale, where you work as a mortician in a funeral home. You're given a body, you have to prepare it, either embalming or prepare it for cremation, and it walks you through every step that happens in that process. Or conversation games can also be quite useful. So there are a couple out there. This is just one that I've used, where in these games you're drawing various cards that might have a prompt question, similar to some of the questions that Ben gave at the start in the poll. So things like, you know, what if there was an envelope containing the date and time of your death, would you want to open it? What song would you want at your funeral? Would you rather be buried or cremated? Just questions that are really helping to start open up conversations about death, again, as a bit of an exposure task. So that's the B in the CBT, the kind of deliberate exposure work. But of course, if we know CBT is effective, we also want to look at some of the beliefs that underpin this fear. And in particular, we want to try and address and challenge unhelpful beliefs around death. So for example, for fears around the dying process itself, it can be quite helpful to start familiarizing yourself, if you're not already, with some of the literature in areas such as palliative care. For example, with information such as more than 85% of palliative care patients have no severe symptoms by the time they die. Or this interesting study, which got some headlines, where researchers asked healthy individuals to imagine they were diagnosed with a terminal illness and to write fictional journal accounts of what they thought they would be writing if they were imminently facing death. And then the researchers compared those fictional journals to the real life journals of people who actually were terminally ill. And what they found was that, in the words of this headline, dying is a happier experience than most people imagine, meaning that the actual accounts of people who were terminally ill were filled with a lot more positive language than the healthy controls expected. So these are just some things to be keeping in mind if you're noticing clients presenting with these sorts of unhelpful beliefs about what it would be like to die, whether that's beliefs like dying will be painful, I couldn't cope with a terminal illness, and so on and so on. Trying to present them with some counter evidence that actually most people drastically underestimate their coping with death and dying. And there are various unhelpful beliefs people could have about death. It could be beliefs about, again, coping, beliefs about how their children might cope if they were to die, for instance, or beliefs about the shortness of life. And again, we're trying to help people see death in a different way. So trying, for example, to actually highlight that humans are living longer than ever, historically speaking, and of course that humans live far longer than almost any other species. So trying to develop more helpful and more realistic beliefs about death and dying. So tying together what we've talked about from exposure and from cognitive challenging, death acceptance is really a central theme, I would argue, in treating death anxiety. And there have been 3 types of death acceptance identified in the literature. So Wong and colleagues identified approach acceptance. This is the idea that I accept death because I view it as a gateway to something better. So I accept death because I believe, for example, that I will be reunited with my loved ones in the afterlife, and that's why I accept death. There is also escape acceptance. So I accept death because I view it as an escape from my current suffering, whether that's physical suffering or mental suffering. And lastly, there's what's called neutral death acceptance. So this is the idea that I accept death as neither good nor bad. I accept death as inevitable, as natural, and outside of my control. So these are the 3 types of death acceptance. Now, all 3 are better than non-acceptance of death, but it's neutral death acceptance in particular that is reliably associated with low death anxiety. So it's neutral acceptance of death that we are going to most want to try and cultivate through treatment. And neutral acceptance of death overlaps quite closely with the philosophy of Stoicism. So, for those of you who aren't familiar with Stoicism, it was a school of philosophy that emerged in ancient Greece. And essentially, the Stoics had one key teaching. That the central teaching of Stoicism is summed up here by Epictetus, who was a former slave turned philosopher. Epictetus says happiness and freedom begin with a clear understanding of one principle. Some things are within your control and some things are not. And this sums up 90% of Stoicism. So, at the heart of Stoicism was this idea that in order to be happy, you must recognize what is within your circle of complete control and what is outside of that circle. The second I start to care about something outside of my complete control, I am setting myself up for suffering. And so I need to, in order to be happy, I need to try and practice stoic indifference to anything outside of my complete control. And death, of course, falls squarely in that camp. There is very little to do with death that is within my complete control. And so the Stoics wrote a lot and thought a lot about death and the importance of accepting it. So Seneca wrote, "Study death always, so that you'll fear it never." So Seneca was really understanding and the Stoics in general, the principles of exposure therapy thousands of years ago. We need to study death always to overcome fear of it, and also recognizing the benefits of accepting death. No man enjoys the true taste of life, but he who is ready and willing to quit it. And so often in the work that I do, I will introduce the idea of Stoicism to people and really get them to try and practice these kinds of teachings and principles. And where appropriate, reading the works of the Stoics themselves on this topic. So the Stoics wrote a lot about death. This book here, How to Die, is a collection of writings by Seneca about death and different perspectives on death. I regularly recommend this book to clients. It's quite short, and you could read it in a day, not even. Of course, with anything you're recommending to clients, make sure you read it yourself first. This book, for example, does contain several mentions of several discussions around suicide. So Stoicism very closely overlaps with this idea of neutral acceptance, which we know has the best outcomes. If you're interested in learning more about Stoic perspectives on death, this is a QR code here which links to a paper I published a few years ago talking about how to integrate Stoic perspectives on death into cognitive therapy. But essentially what we're going for here is trying to cultivate neutral acceptance of death as something natural, inevitable, and outside of our control. That's a sort of nutshell summary of some of the main treatment principles for death anxiety. I'm going to bring us back to the case example I described earlier of Jane to show how you can integrate some of these into treatment and how you can monitor change with the DABs. So these were Jane's initial scores on the DABs. So if you remember, this is the affect subscale at the top, then we have beliefs, then we have behaviors. So from Jane's responses, we were able to pull out some of the most commonly endorsed beliefs she had about death. This included things like it would be horrible to die alone, and the beliefs around not being able to cope. I couldn't cope with growing old without my loved ones. I will lose a loved one suddenly and it will destroy me. So this told me early on we were really going to have to work on some of those beliefs around her coping ability in the face of death. And then we also have her responses on the behavior subscale, where there were a couple of key things that she regularly avoided. She engaged in a lot of thought suppression, as you can see here. So she would often avoid thinking about a loved one dying, thinking about herself dying, as well as various other things, such as watching a film or TV show with a character who is dying. So this also helped us collaboratively identify what would be some of the tasks that it would be helpful for Jane to do as exposure tasks based on her responses on the DABs. So I'll tell you a little bit about what treatment looked like for Jane. So we started off with focusing on challenging some of her beliefs about death, particularly some of her beliefs about how she would cope if her loved ones, particularly her husband, were to die. We then moved on to, as well as challenging some of her beliefs about non-existence, beliefs that death does involve, for example, a blackness and abandonment and the sorts of things that Jane felt it did. We then moved on to some exposure work. Jane would be reading books about death. She read some Yulom. She read some other non-fiction books about death, about terminal illness, and she watched some different documentaries and films to do with death. We then identified that for Jane, there was some room for improvement in some of her, what we'd think of as protective factors against death anxiety. So, for example, she described having very little meaning in her life. And so once we'd built this solid foundation around the exposure therapy and the cognitive therapy, we started to work on trying to improve her sense of meaning in life, which we know tends to help buffer fears of death. And lastly, because of these fears about how she would cope if her husband died, part of what was driving this fear was that she didn't really have many other social supports other than her husband. And so, in addition to trying to target and reframe some of her threat predictions about the loss of her husband, we also started to work on building up some of her social supports outside of her husband. So, this is a graph of Jane's subscale scores on the DABS across treatment. So I saw Jane over the course of a year, and I have some of her scores at 4 time points. Now, importantly and completely unexpectedly, very early on in treatment, a couple of sessions in, the one family member that she was still actually very, very close with, which was her stepfather, was actually suddenly diagnosed with cancer. And so very early on in treatment, Jane was having to grapple with potentially the death of her closest person outside of her husband. And so in a way, this really created kind of more impetus for Jane to really work on this fear because she was having to deal with the potential death of her stepfather while also grappling with what that was doing for her own death anxiety. And in fact, across the course of our work together, her stepfather did die. She saw him deteriorate very quickly. She saw him become quite skeletal. And, this, of course, was quite a big trigger for her and her death anxiety. But Jane worked really hard at still overcoming this fear and still persisting with all of the work we were doing alongside dealing with the grief around her stepfather's death. And so I raise this as an example of how you naturally things are going to come up for yourself as a clinician, for your patient while doing this work. And I think that's more reason than ever to be really trying to work on cultivating this kind of death acceptance. And so despite encountering what would have been the biggest loss of Jane's life, she still managed to see these improvements in her affect, her beliefs, and her behaviors in relation to death anxiety. And when we look at her total death anxiety score, what you can see here is that it started off at 70, and across the course of our treatment, it dropped down to 55. Now, 55 is right on that clinical cutoff, if you remember. And you can see here it's right on the border. And yet, at the end of treatment, Jane felt she was happy with the improvements in her death anxiety. So she was no longer experiencing the nocturnal panic attacks she'd had. She was no longer excessively preoccupied with the idea of her husband's death. She was no longer ruminating on deaths she heard about in the news. She was able to get to a point where she was much less troubled by the idea of death. And so I think this is important to think about in terms of our goals for treatment as well. We're not necessarily always aiming to completely eradicate this fear. There's a certain level of death anxiety which is normal and in some cases protective. What we're aiming for is to reduce distress, reduce dysfunction, get the person to a point where they feel they have greater ability to cope with these thoughts, or the thoughts are less frequent, less distressing, causing them less avoidance, and so on and so forth. And so even though Jane was right on that still cutoff between the clinical cutoff and what we'd say is the normal range, she felt the treatment had been successful for her and that she actually no longer needed further therapy at the end of this time together. So I thought I would flag just in the remaining time we have an online treatment program that we developed for death anxiety a few years ago. I'm aware that, for many of you, you'll be wanting to do your own work on the things that your clients are presenting with, and you might not always feel you have the time in session to be working kind of, solely on death anxiety. For many of us, we're working in a Medicare framework where we might have 10 sessions with someone, and someone might be presenting with OCD or panic disorder, and you might see the benefit of death anxiety treatment for them, but you might also be mindful that you've got 10 sessions to produce change with someone quickly. And so for that reason, or partly for that reason, we developed this online self-guided death anxiety treatment program that people can work through at their own pace, and they might not necessarily need a therapist input throughout that. So this could be something that you might recommend kind of supplementary to the work that you're doing with someone. So we developed this as a standalone treatment. It's completely automated. It requires no therapist input. It is an individualized online program, meaning that the program itself will develop unique exposure therapy exercises, cognitive challenging exercises, based on the clinical formulation, based on the information an individual puts into the program. And it's CBT based. So it consists of 7 evidence-based modules that are targeting the things we talked about today. So things like cognitive reframing, exposure therapy, and so forth. Now, we had a small pilot study where we had 20 participants with mental health conditions. And what we found was that for those who completed the program, 90% made a clinically reliable improvement in at least one death anxiety subscale, and 60% made an improvement of their total death anxiety score. So this was just our phase 1 pilot study. We are, as of, what week is it? As of last week, we've opened recruitment for our first large randomized controlled trial of this program. So this is a large RCT where we're recruiting people who have high levels of death anxiety, who are interested in getting access to this online treatment as part of the research trial. So if you would like further information about this, or you might have some clients or colleagues even who you think this would be relevant for, there's a QR code here, or you can go to the trial website, which is overcomedeathanxiety.com. Lastly, if you're wanting some more resources, these are a couple of books on the topic. Models is a really good summary and introduction for clinicians or for the general public. This won a couple of national and international book prizes, so it's just a really good overview on the role of death anxiety and how we can start to face it. This book here, Free Yourself from Death Anxiety, a CBT self-help guide for a fear of death and dying, I published with Professor David Veal in the UK. This is a much more kind of practical self-help book that contains a lot of psychoed, a lot of worksheets and exercises. You can recommend it again to clients for them to work through. You can use it yourself and kind of make copies of the worksheets and things like that for therapy if you wish. This is kind of the practical, very CBT-based guide. And then lastly, this is a textbook that we brought out with Springer, which goes through the big 5 existential concerns and treatment for those, of which death is one of them. Lastly, in terms of further resources, you might like to take a look at our website for the Menzies Anxiety Centre. We offer treatment, supervision and training Australia-wide and internationally. And we have a whole page dedicated to freely available resources on our website. So if you're interested in listening to podcasts, reading articles, reading freely available journal publications, you can take a look at the resources page on our website at the Menzies Anxiety Centre. That brings me to the end of my talk for tonight. I think we're right on time. But thank you so much. And if you have any questions that we don't get to tonight in this last Q&A section, please feel free to reach out to me via email here.
And there are lots of questions. So for the last 15 minutes, guys, I'm just going to show you a couple of things on Novopsych, and then we've got some excellent questions that come in. I've got a list of them, so do stick around for that. Rachel, what a fantastic presentation. So I show people how they can get the death anxiety and beliefs and behavior scale available on NovoPsych. So Rachel, congratulations for developing such a wonderful scale. I come across lots of scales. You've obviously thought it through and you've validated in a number of populations. And so really well done. And thank you for allowing us to have it here on NovoPsych. So on the website, novopsych.com, we've got a bunch of information about the scale, detailing the three subscales. We've got some detailed information about how it's scored, the graphs that get produced, and importantly, those graphs that Rachel showed are automatically created. So if you administer the DABs the first time, you'll get a graph like this. And the reason I love this graph is that it contextualizes the results in comparison to what's normal in the community. Obviously, having some level of death anxiety is pretty normal, and we've got that here in the average range. But when we go over these ranges is where it's clinically significant and might be interacting with other mental health concerns. So that's the graph that you'll get the first administration, and then on subsequent administration. So you can see here, this has been administered twice. It will graph the total score over time and also the subscales just automatically. And the way to do that in NovoPsych, if you haven't got an account yet, do press sign up here and get a free trial. And when you do, you'll log in here and you'll be given these options. For example, if you wanted to email the DABs, you would go in here and then you'd select a client and then you'd search for the DABs. And then what you could do is you could either copy that URL or you could send an email. And so here it says, Dear Ben, this is an automated email set up by Dr. Ben Buchanan, who would like to fill in a questionnaire to check in with you. If you press done, that will get sent to your client. And that client can fill it out in their own time. And those results will automatically come back to you. That's enough of me showing you that. So Rachel, there are so many questions. It strikes me that I was thinking during your presentation that and wondering about whether meaning and purpose has to be one of, do you think it's the strongest buffer against maladaptive death anxiety? For example, I hear people like turns of phrase like, I'm devoting my life to this larger purpose.
Mm.
Is it the strongest buffer against it?
It's a really good question. I would definitely put it in the top three. So, how they all compare to each other from a data point of view, I'm not too sure which one would come out as the winner, but the top three, summarizing the research, would definitely be meaning in life. Self-esteem, we saw how self-esteem is one of the two terror management buffers, and we know that people with high self-esteem have less death anxiety. And there's more and more research suggesting that attachment, so secure attachment styles, but also close relationships are one of the key buffers of death anxiety. So those three things I would say are the most key protective factors against this fear.
So on that, like the self-esteem thing, right? Because it used to be that we all thought that self-esteem was the best thing ever, and that the higher the self-esteem, the better. And then more contemporary sort of understanding of it is that self-esteem is good, but having too high self-esteem can be pathological. Um, and I suppose a question related to that, is there such thing as death anxiety, which is too low? For example, I think of psychopaths who have reckless disregard for their own safety. Um, is really low death anxiety a problem?
It's a really good question. I think it's really case by case. I mean, definitely we know that death anxiety exists on a spectrum, and there are always going to be some people in that lower half of the spectrum that have just very low death anxiety. For some people, that is going to be because of things like, callous unemotional traits, psychopathy, and so forth. But for other people, it might just be that they've reached a place of, very high death acceptance. So I wouldn't say it's necessarily a problem. I suppose it comes down to the impact it's having on the person's life.
Yeah, right. So a few questions came up. So one from Cass. She says, I work with people who have degenerative disease and wonders about research on this sort of environment. And Renee asks, are there any differences in death anxiety to those who are close to death at the end of
Mm.
life or even voluntary assisted dying? For some clients, death anxiety isn't just a future hypothetical, it's an immediate reality. Is death anxiety normal or even helpful in these contexts?
Yeah, two really good questions. So, a general comment, I suppose, is that we know shockingly little about death anxiety in chronic illness. It's mostly been studied in cancer, and even there in cancer, in advanced cancer, we know that again, there's a spectrum, there's a normal curve where, you know, again, a level of death anxiety at end of life is normal, but again, for some people, it's going to be at the point where it's causing much more distress, even given the situation. We know that the types of concerns people have about death are also quite different depending on, for instance, if they are at end of life versus not. So people at end of life are much more likely to have concerns about the impact of their death on loved ones, for instance. Um, but in general, death anxiety and chronic illnesses is something that's been vastly understudied and something that in the past couple of years I've been trying to do a lot more research on.
You're devoting your life to that, I see.
Yes.
Um, Jane asks, have you seen people who are suicidal, who also have intense death anxiety? In that context, is death anxiety ever protective, and how does it interact with
Mm.
suicidal ideation generally?
It's a really good question. So, definitely, when there are risk factors, you want to be really careful with this kind of work. I've certainly worked with patients where their death anxiety is so severe that it causes them to feel like their life isn't worth living. And that's a case where you would be wanting to treat the death anxiety because it's that's driving the distress and the suicidal thinking. For other clients, death anxiety can be protective against suicide. So, in those cases, you would certainly want to work on reducing someone's risk, making sure they're stable before doing this work. If people are interested in reading more about death anxiety and suicidality, one of my PhD students, Melissa Sims, has published a systematic review on that topic. I think it's listed on the publications page of our website on the Menzies Anxiety Centre if you want to read more about that in particular.
All right. And Lisa just said that she's got an 84-year-old mother who's got rheumatoid arthritis and is constant pain, and says she's
Mhm.
got no fear of death. Whereas another attendee says that they work with older adults and come across a great deal of death denial. They don't,
Mm.
they don't want to talk about it. In fact, the other day, I was talking to my granny. She's 95, and she said, "Oh, I'm a little old lady. I'm 95," and I said, "Do you think you'll make it to 100?" And she said, "I'd prefer not to talk about it."
Mm.
And so I never will again.
Mm.
Um, any advice for me or the attendees who've asked about how to work with older adults in this framework?
Yeah, it's a really good question. So we know that on average, surprisingly, the older someone gets, generally speaking, the less anxious they get about death. And there are various different reasons for that, which we probably don't have time to unpack. So, by and large, death anxiety peaks in early adulthood between about 18 to 24 or so. But of course, that doesn't mean that there are no older adults for whom this is a really big problem. And it's very tricky when there is that denial and avoidance of it. Um,
Mm,
I think, as with anything like that, all you can do is create a kind of safe, comfortable place for the person to talk about it if they wish. But it's very tricky when people are not willing or not able to have these kinds of conversations.
And I suppose if they've done 90 years of life not talking about it,
Mm,
that bringing it up, um, probably isn't going to work.
mm,
Yeah. So what's something I wonder about, like legacy, later in life seems to be really important, and legacy in general as perhaps an attempt to maybe deny or cope with death anxiety. Think
mm,
the pyramids or I also think about it in the context of children and people having children as a form of legacy. And I
Mhm.
wonder, in the context of, ever increasing life expectancy, but on the flip side, lowering fertility rates. Um, uh, you know, well, I wonder, does having kids reduce death anxiety, and how do you think it impacts or is interacting with fertility rates and longevity?
Mm, Another really good question. So we know that death anxiety is one driver of the desire to have children. It's certainly not to say that's the only reason people have kids. But we know from mortality salient studies, if you give people these subtle reminders of death, they have a stronger desire to have more children than they currently do.
Right.
Um, but as you said, birth rates are declining in many parts of the world. And I suspect that means for some people, they're choosing alternative ways of finding legacy. They might be choosing the career path, or some other form of giving back, leaving their mark on the planet, whether that's positive, negative, as opposed to having kids. So there's various ways people strive for legacy, and children is probably one of those different paths people choose.
You're right. So you mentioned that death anxiety increases people's desire to purchase luxury goods, and
Mhm.
something that I work in is people with body dysmorphic disorder and people seeking cosmetic procedures, often
Mm.
that have the expressed desire to look younger. And I noticed, as did one of the audience members, that BDD had the highest correlation with death anxiety out of all of this disorders you showed, and of course, body dysmorphic disorder being highly related to OCD. Um,
Mm.
will purchasing luxury goods or getting cosmetic procedures actually reduce death anxiety, albeit perhaps temporarily?
It's a good question. I suspect not. That's just kind of clinically. I don't have any data to back that up, but I think often these things, might give temporary reductions in relief, but are not a permanent solution.
So a handbag a week might.
Yeah, that's not what I prescribe. Yeah.
Okay.
I think on a societal level as well, this is a really big problem that I think more and more we see this denial of aging, various attempts to stop or reverse aging. And I think as a society, we're not very good at accepting aging and death. And so it's, partly up to us as individuals to work on this for ourselves, if that's something we want to do, but also very hard when we're in a society that holds very negative beliefs about aging and really values appearance.
Yeah. Um, Meg asks, death anxiety seems to be the ultimate abandonment.
Mm,
And Meg asks, what's your sense of attachment anxiety and which to treat first, attachment disruption
mm.
or death anxiety?
Look, it's a really tricky question, and I think it depends on a few things. I think your clinical impression. So definitely there's a relationship, and the case I gave of Jane is a perfect example of that. She did view death as an abandonment and had very insecure attachment. In terms of which to treat first, I think with any decision like that, it's going to be about, feasibility, which is what's your clinical impression of which is going to be harder to shift or what's going to give you the biggest bang for your buck, so to speak. And also, I guess, the client's willingness. If the death anxiety, for instance, for them feels too tough, particularly at the start of treatment, you might take a more attachment based approach, or if they have a really good buy into the death anxiety stuff and they can see the importance of death in their life, they might just be more on board with tackling that. So no black or white answer, unfortunately, but it's going to be just using your clinical judgment around that.
Yeah. And so, you know, everyone in this audience is obviously also a human, and so also might have death anxiety. I think I mean, in preparing for this and reading lots of your work today, felt like a little bit anxious, but also at the same time, perhaps was able to take it easy and to cherish things. And I suppose I'd encourage the audience to think about this for the rest of the day and into the evening to think about how you'll go out after this webinar and and show up in your life today and tomorrow. Because I've done a lot of thinking. Rachel, is there any sort of thoughts you'd have about the audience, spending an hour and a half thinking about death and what they might be able to do or take from it themselves?
Look, I think we want to practice what we preach. And I think the more we can work on accepting death ourselves, the better. And I think that accepting death is really the key to living a more authentic and deliberate life. If I can
Mm,
accept that I'm mortal, that
yeah.
I'm not going to be around forever, it really allows me to think about how do I truly want to spend the time that I do have.
Yeah. Well, Rachel, thank you so much for spending an hour and a half with us tonight. We've only got 750,000 hours in our life. And so thank you for giving 1.5 hours of yours to us. And thank you to the audience for devoting 1.5 hours of your life so that you can better serve your clients. I think it's great that we're all committed to that purpose, which is larger than ourselves. If you've enjoyed tonight's webinar, we do have another one coming up on why patients don't fit into the DSM-5 box, rethinking psychological assessment with the hierarchical taxonomy of psychopathology. And Rachel, once again, thank you. And in the words of Dr. O'Dwyer, who I saw said this in the chat just moments ago, she said, "This is the most fabulous training I've had in ages." Thank you so much, Rachel.
Oh, that's lovely. Well, thank you everyone for making time in your evening tonight to come along. And thank you, Ben, for inviting me to present.
No problems. Bye.
Thank you.